afternoon. My name is Avery Garrison. I'm 15 years old and I'm a patient with MSMDS. I am honored to be introducing our next speaker. This person has not only helped me by performing 2 aortic surgeries that have saved my life, but he's just an amazing person overall. With that, let me tell you a little bit about him. Because of the ACT2 mutation, those with MSMDS will require aortic repair or replacement at some point. Constant cardiac monitoring is important as an unintended rupture can lead to life-threatening outcomes. Cardiac surgeon at Mass General Hospital in Boston, Dr. Bloom, specializes in congenital heart defects and connective tissue disorders. He is here to present about aortic repair and replacement for the MSMDS community. Please help me in welcoming Dr. Jordan Bloom.
Well, thanks a lot, Avery, and thank you very much. And this meeting is a super special meeting for me for a lot of reasons. Not only I believe 3 of my patients and their families are going to be here throughout the meeting. Avery, who asked if it was okay if she introduced me, is incredibly special and an amazing thing. Avery was the first patient with MSMDS that I operated on. And Dr. Cameron, who you just heard from, who mentioned me as a colleague, the story is a little bit deeper than that. When we at Mass General had the great honor of having Duke Cameron come to our faculty, I was a trainee at that point, and the training to become a heart surgeon is fairly long, and I did it in a little bit slower than normal. So it took me about 11 years after I finished medical school. And during that time, I identified Duke Cameron as a mentor and somebody who I wanted to try to embody both in his clinical skills and in his interpersonal skills. And we connected well. And basically through that relationship, I identify him really as my sort of primary mentor. He's the person that taught me how to do the kind of surgery that I did for Avery. And he's still somebody who the other night spent 45 minutes on a Zoom with me reviewing difficult cases. So it's really been an honor to learn from him, and I certainly wouldn't be standing up here if it weren't for him. So thank you, Duke. And with that, I'll start the presentation. So I am not a pediatric surgeon. I don't operate on kids. In fact, I'm not credentialed at Mass General to operate on children. And so therefore, when I met the first patient, who was Avery at age 13, I believe, when we first met, she had been given an intervention threshold actually by Duke Cameron earlier in life, which is amazing at 4 centimeters. And she came to Mass General not for me. She came to Mass General because of Patty Mussolino and Mark Lindsay and all the people that have expertise in this disease process. And, I was the guy, doing Duke Cameron's job at a much sort of more junior phase in life, although I had developed a fairly high volume aortic practice. So the topics that I want to discuss today are how I got into this, and you've already heard a little bit about that. What are the surgical considerations in the adult-sized people that we meet, like Avery, who you just met? A little bit just about how do we actually do aortic surgery. Dr. Cameron introduced some of the principles of the heart-lung machine, but to do the kinds of operations that I did for Avery and the others, we actually have to completely stop blood flow to the body and the brain. And usually that is not associated with good outcomes unless you do it in a very careful way. And I'm going to present the three patients I've taken care of with this disease, and then just share a little bit with you about what I've learned. And then I think we'll invite Dr. Cameron back up and just see if you guys have any questions, surgical or otherwise. This was an email from Mark Lindsay dated September 6th, 2023, not that long ago. Hoping you can look at a scan if you're around. I have this child who's 13 years old. She's 5'9", 62 kilos. I'm not going to read you the whole thing. She has a high-risk syndrome. Full disclosure, guys, it's something I had never heard of. I had never heard about in training. I trained at a pretty good place with pretty good people, but this was just not something that I had heard of. And talks about reaching out to Duke because, none of us would ever do anything to a rare disease without speaking to Dr. Cameron. And this is how it all started for me. And so with that, you know, the surgical considerations for this disease process you've already heard about. All of these people that I will meet as legal children or adults, but usually adult size, are going to have had prior surgery. And you heard that PDA is most common and an AP window is not common, but Avery was born with that problem. And there are really two considerations that I'm going to try to, you know, teach you a little bit about today. And we use words proximal and distal, and that kind of means near and far, and that relates to the heart. The heart is the most important thing in the world and the most important organ in the body. And so the closer you are to the heart, we'll call that proximal, and the further you are from the heart, we'll call that distal. And the aorta is the big pipe that comes out of the heart. Okay, so in this picture, the heart would be here. I'm going to honor Dr. Cameron with two fists. And inside here, there's a valve. It's called the aortic valve. And then you have the ascending aorta. Just before the ascending aorta is something called the aortic root. That is the home of the coronary arteries that come off and then branch to give blood to the heart muscle. And then that aorta turns, and in the picture, it looks like it goes from left to right, but it almost kind of more goes from the front to the back. And then off of it come the blood supply to the upper body, to the arms, to the brain. Then it goes down the back and it gives blood to the spinal cord, which is really important. And then it gives blood to all the abdominal organs and branches into the blood supply to the legs. Okay? So this talk is really about the aorta, and there's some pictures over there of some of the wonky things that can happen to the aorta, and I'll show you more wonky pictures when I show you some of the CT scans of our patients. But really, the aorta can become abnormal, it can become dilated, it can grow in any way that you could ever imagine in any part. And that extent of dilation is sort of probably the most important thing in thinking about how we can fix what the problem is. This is a picture of a modern day heart-lung machine. Heart-lung machine was invented really at my former medical school, which is not Johns Hopkins or Mass General. It's a place most of you have probably never heard of, called Jefferson Medical College, which is the oldest private medical college in the country, in Philadelphia. And it's a really neat place, but it certainly doesn't have all the important contributions to modern medicine that the other two institutions do. But a man named John Gibbon, who did spend some time at MGH, and I like Duke's story. If you're at MGH, so you will say here in Boston, you'll sometimes hear that John Gibbon is an MGH guy. He did some research at MGH, but this is the modern heart-lung machine, and he first used it in 1953. And it's interesting that you heard that heart surgery started before then, but it didn't start with the use of the heart-lung machine, and the heart-lung machine has really been the ticket to enable us to fix problems like the ones we're going to talk about today. And it's a really, really simple concept, which is that if you imagine Dr. Cameron's picture, there's blue and red, and if you take all the blue blood out of the heart, and you heard him say it's not really blue, but all the deoxygenated blood out of the heart, and you send it to a device that can do the job of the heart and lungs, which is not that complex. You need to add oxygen, remove carbon dioxide, pump it forward at some pressure, and then maybe regulate things like temperature and some other metabolic things. And then you return it to the red place, really anywhere in the body, then the heart is bypassed, and the heart and the lungs are not necessary anymore. So when you're on bypass, which you've probably all heard of, you're on the heart-lung machine, and a very talented person or two is sitting in front of it, running it. We call those people perfusionists. And once you're on the heart-lung machine, the heart is beating in the chest, but it's completely empty, and it's beautiful if you have good venous return and good drainage and an empty heart. And then you can do whatever you want with the heart. You can stop it. You can take it out. You can put a new one in. You can open it up. You can fix things on the inside. You can fix things on the outside, and the brain and the body stay alive because of the bypass machine. Okay, so that's sort of the basic fundamental principles of how we do most of what we do. I'm going to move on to some of the cases here. So Avery gave me permission to tell you that this is what her CAT scan looked like when I met her. And if I just remind you of what normal looks like here on the left, what you can appreciate here is that this picture on the right has some areas that look larger than maybe some would anticipate. And so Avery was born actually with the AP window defect that you heard, and she had that repaired very early in life. And some of what we do is associated with complications, and she unfortunately had compression of one of her airways, the airway to her left lung. And at a very young age, that required a stent, and that stent didn't work very well. And then ultimately, she underwent an operation to remove that stent, and then did well for a long time, and came to me with this scan. So, without getting into too much detail here, basically, Avery needed to have all of her aortic tissue replaced from where the aorta joins the heart. Now remember, there's a valve in there, and that valve's important. And then she needed to have the blood vessels to her brain fixed because those were too big. And then she also needed to have the blood vessel that goes down along with her spinal cord fixed because that's too big. And while there are some kind of crazy ways to do that in one operation, we decided on a two different operation strategy. Not only to make it a little bit less morbid for Avery, but also to make it safer. And so that's what we did. We spent probably somewhere in the neighborhood of about 20 hours. I must have talked to maybe 20 different surgeons from across the globe, people that I knew. And the person that I had spoken to that had done the most of this operation had done 3. And he was the person that, was telling me about his experience. And some of these, there was somebody in Texas, there was somebody in California, there was somebody in Italy, there was so you get in little pieces of very, very little bits of information. And really what I mostly relied on were 2 things, which was the education I had from Duke Cameron. And then I asked my other mentor, who's a very well-known aortic surgeon at Mass General Torres, if he would be willing to help me with Avery's operations. And this is the protocol that we designed. You can't read any of that intentionally, but this is pre-op, intra-op, post-op, all the considerations, all the concerns. And this was at Avery's bedside. And this kind of dictated what drugs we would use and how we would do things. And probably the most important operative consideration for us is the blood vessels in the brain. For a lot of patients with this disorder, don't compensate well. So low blood pressure is bad. And in our world of heart surgery, there are a lot of times where the blood pressure might go low, come up, might go low. And we wanted to minimize all of that for Avery and for patients with this disease process, because you may have heard this term of the moya-moya-like circulation. So everything here was basically built around how careful can we be about never having low blood pressure. That means drugs to treat pain, drugs to treat this, drugs to treat that. If the heart gets too fast, everything we give can cause low blood pressure. And I think that's really what the most important thing about the treatment of patients with this disease is: avoidance of low blood pressure. So after we did it, we did the first operation. We did a reduced sternotomy, meaning get back in here safely, and ultimately ended up replacing her aortic arch, trying to repair her pulmonary artery, because as you can imagine, if a big patch was sewn between those 2 vessels, that area gets very scarred. And that was actually probably the most challenging part of Avery's operation. I'm not going to tell you about some of the inelegant things that happened early on, but I learned very significant, in a way that I will never forget, that scar tissue can be very challenging to sort through. And then we replaced Avery's root, and Avery ended up with a valve replacement as well, and replaced her ascending aorta. So that was the first operation. And, I'm not going to bore you too much with the details. When I first was making my talk, I didn't exactly know who the audience was, so I did include some of the technical stuff. But the important part here is not to teach you guys how to do heart surgery, but to just show you that you start with something that looks like this, and you end up with something that looks like this, where we use Dacron, which is a fabric that doesn't grow and hopefully lasts forever, to end up replacing everything that's too big with and sewing to things that are normal size. And then I was trying to remember, I should have looked this up, but what did we wait? Did we wait 6 months, 3 months? I can't.
6 months.
6 months. Yeah, Avery went back to school and then came back, and then from the left chest we did a left thoracotomy, and we replaced her descending aorta, and so this is what we started with, and this is what we ended with, and things don't look completely normal on the screen, right? But that's just because a lot of the surgical material and the graft and such. But all of this aneurysmal or tissue that's too large is now gone, and Avery has done incredibly well, as you can see by meeting her as she introduced me. Let's get Avery. This is a lot of surgery for somebody at any age to get through, and she did just absolutely fantastic. The second patient who's not here is a 16-year-old female. She was born with a patent ductus and underwent repair. Interestingly, her repair failed. She recanalized, meaning that the patent ductus actually was able to recanalize. And Dr. Cameron could tell us a lot about why that may happen. But she ended up having a stent in there. And the significance of that is that just like patch material, the stent can cause a lot of inflammation. And this made her operation a little bit more technically complex. But if you look at the first part of her aorta and her aortic root, it looks a bit like Avery's. But unlike Avery's, her descending thoracic aorta, the part that goes down the spine, is very small. And none of that was large. But she does have a lot of dilation into the aortic arch. And you can see the first two branches there that come off have a very large base. So the plan for this patient was to also replace her aortic root. Her valve was a little bit different, so the hope was to preserve it and then to construct our connection here in this particular zone, which we call zone 2. And so that's what we did. For her, this was also a redo. I was able to preserve her valve. She also had a little tiny hole inside of the 2 chambers of her heart that we fixed. And she too needed a pretty complicated patch repair of her pulmonary artery, probably because of inflammation related to the stent. And so that's her pre and post, also looking significantly more normal in terms of diameter. And then lastly, we had an 18-year-old female that was recently diagnosed, and she too had multiple prior operations, including PDA repair, and this was her anatomy. So, for the folks in the room that haven't seen a lot of CT scans, there's some real similarities between these three and the way that this disease process evolves. But obviously, this patient's scan looks a little bit more like the second patient's scan, where her descending is fairly normal up here. But you see, as you progress down below the diaphragm, this is a kidney that kind of shows up. The aorta is more dilated there. So these cases illustrate kind of how different this disease can affect the aorta. And so we did an operation on her, just like basically the patient's second operation. But this patient did not need a root replacement because the first part of the aorta where it comes out of the heart was a more normal caliber. And this is the final reconstruction shots of her operation. So, what have I learned from this? This is a very famous quote, and I think it's the most important thing, is that, for parents, for patients, this is not a 1, 2, 3, 4, or 5 person effort. This is a massive team effort. The amount of multidisciplinary collaboration that we have to take care of these patients was frankly a bit annoying. And Avery's parents can certainly are chuckling because, we had so many cooks in the kitchen that every now and again I kind of had to come in and be a dictator and say, no, we're done with all this fussiness. We had pediatric providers and adult providers and child life specialists who Avery never liked. And she doesn't identify as a child. But those people are all critically important because they all think about things differently. They come from different views, different lenses. These are not all doctors. We're talking about physical therapists, occupational therapists, respiratory therapists, all really critical, I think, to the success of caring for these patients. I actually think the surgery is the easy part, and everything that happens after is much more challenging. Patient selection, center selection, super duper careful surgery is very important, but it's really this perioperative care that I think is incredibly important. And this is Mount Everest. And when I kind of first met Avery and heard about this, I kind of viewed this disease as Mount Everest, but people climb Mount Everest all the time safely. They just have to do it right and they have to do it carefully. And so I think, for the folks in this room, the thing to take away from my talk is that this is scary. It's big. These things are big operations. They're associated with risk. But, if done correctly at the right places by the right people, and I don't mean me, I mean the team, people like Patty, people like Mark, um, that we can have really good outcomes. Dr. Cameron finished his talk with the same message, that this is big, scary stuff, and it's okay to be scared of it, but we can do this stuff safely. It just has to be done correctly. And these are some just awesome pictures of my three patients. Two of them at prom, and Avery at Halloween here. And these are the three of them post-operatively in my office at the 6-week post-op visit after 6 weeks after they were discharged from the hospital. And these three pictures are in my office, and I look at them a lot. Be re-energized because it brings me a lot of extreme gratitude. And then I can't not thank really the key members of our team at Mass General, and Duke is first for a reason. I would never be able to do anything that I do without him, without the support of Tor Sunk who's next to him. I mean, Mark Lindsay, I think people in this room have to know, as a real world expert in genetics disease. Patty Mussolino is essentially the encyclopedia for the disease. And then you don't know Mark Wong. He was the anesthesiologist that helped with Avery's case, and he helped put together our whole perioperative principles. And then the big picture is probably the guy that's best at preventing death in the world. That's Jerome Crowley. He's an anesthesiologist who, anytime anybody's sick, we want him around. So he's taken over for Mark Wong as our anesthesiologist for these cases. So this is a very small part of the team. It doesn't include the nurses and all the therapists that don't have the pictures of. But it's been a really interesting journey to embark on, despite only having experience of 3. So thank you very much for your attention, Avery. Thank you for your very sweet introduction. And I think I'll stop there. And if anybody has questions for Dr. Cameron or myself, I'd be happy to chat. Thank you.
There's a Zoom question.
Oh, sure.
Yeah.
If you want to come up, or is it?
You should say.
The first one was for Dr. Cameron, the other one just came in for Dr. Glee.
Okay.
Well, let's take it whichever order you like.
Sorry.
The first one's for Dr. Cameron. Okay, Dr. Cameron, the question is, which threshold do you use for aortic surgery to prevent dissection?
So the question was what
threshold I am?
Well, what threshold? Oh, okay. So question, and this is one of the most common questions that we're asked: when is an aorta too big? And the concern is, if it gets too big, that it can freely rupture, which is usually fatal, or it can develop a tear just on the inner layer called dissection. The aorta is, it has 3 layers. The wall has 3 layers, like an onion. It has multiple layers. And when a dissection happens, the inner layer splits and the blood gets into the wall, and the layers of the wall start to peel apart like an onion. It's very painful, and that's fatal too, but you often have time to the chance to get to a hospital and have it repaired. So the question is, the key question is, when do you do this surgery to prevent a rupture or dissection? And I'm not trying to evade the question, but the answer is different for every single patient. It depends on what the mutation is, the age of the patient, whether it's been growing rapidly or whether it's been stable for the last 5 years. But the absolute size is important. And at our meetings, we argue about this all the time. What should the threshold be? And I think it's different for every single patient. 5 centimeters, which is the same as 2 inches, that's too big probably for this disease. But does every 3.5 centimeter or 4 centimeter person need an operation? It's a very complicated clinical judgment. It's not medicine by numbers, really. So did I evade the question successfully? I should ask you.
Well, I mean, this is something we deal with every day in our clinics. for all patients, patients with and without syndromic defects, patients with and without connective tissue diseases. And, you know, a couple of the sort of principles that I think are important is LeBron James probably has a bigger aorta than Avery, and that's probably okay. He's got more blood flow that needs to go to his body. So, you know, one of the things we try to do is think about how big is that aorta for you. And that gets back to Duke's point of a personalized approach. The rate of growth is probably as or more important than the absolute diameter. We don't always have a growth rate because often these are found and then you're asked to deal with them. But if you have interval data, multiple studies, that growth rate can be really important. Other things like patient's blood pressure, patient's activity level. If you're a bodybuilder or you're interested in CrossFit or things like that, we might be a little bit nervous about your aorta being larger than, you know, if you sit in a chair all day doing nothing super physical. So I'm only saying this to provide a little bit more evidence to how bespoke and personalized these need to be. And within the MSMDS Act 2A community, you know, we're always kind of starting to worry around 4. 4 was the number that was given to Avery at one point, but there are definitely scenarios where we might consider smaller. The mistake is that these are complex enough things that we don't want to operate on everybody that's a little bit dilated. But I agree, evading the question is really the challenge. It's really, you know, what we do, and pure diameter based decision making is not something that we support.
How many have heard of Z-scores? Do you know what a Z-score is? I mean, you can understand a measurement, whether you're talking inches or centimeters, that's pretty clear. But a Z-score is a way of taking that number and adjusting it for the size of the patient. So that a Z-score of 0, this, you know, I could talk about the bell curve and all that, but I don't remember that well enough from college to be able to articulate it. But there is, for every person who is a certain size and age, a so-called normal or average size of their aorta, and it's different at different levels of the aorta. So if you have a completely normal size for a completely normal size aorta for somebody your size, age, and so forth, your Z-score is 0. 0 means the average. And then if you're at Z-score of 1 or 2, your aorta is bigger, and it's according to the bell curve. So if your aorta is a Z-score of 2, then you're up in the 90th percentile in a bad way. That means your aorta is way, way up there. That's what the value of the Z-score is. It helps you adjust for basically the size of the patient mainly. But I caution everybody to take that with a grain of salt, because the problem with using Z-scores is that when you get into the extremes, either very small or very large, that a small change in the measurement will translate to a huge jump in the Z-score or fall in the Z-score. But that doesn't necessarily mean that the risk of a rupture or dissection is 3 times higher. We out in the tails of the curve, I think the Z-score tells you how abnormal it is, but it still doesn't tell you how likely it is to rupture or not. Is that clear? That's a concept that's hard to get across. So yeah, it's a way of normalizing, we say, or adjusting it for body size, but it's not perfect.
Thank you.
Yeah.
Thank you. Okay, Dr. Bloom, this one was for you, from Adam Caruso. So could these repairs using artificial materials still be used after a Lecomte maneuver and left stent is performed? My son had the same issue after his coarctation procedure. Compression completely occluded his left airway and compressed his pulmonary arteries.
Well, thanks for the question. I mean, so the Lecomte maneuver is something that we don't have to get into, but it's something that's done for a particular defect or repair, and it can certainly make getting to the aorta a little bit more complicated. Lecomte Never thought about that. But I think the short answer is that I don't believe there's an anatomical contraindication, meaning I don't think there's a certain anatomy that would have us say this is not possible. Each of these prior operations that maybe modifies the anatomy that we would consider normal may add complexity. It may also mean that there are that different surgeons or different centers might be better equipped to deal with certain things. But I would not view a Lecomte or anything that you described that Adam described as taking a surgical option off the table. I think it just only means that we need to be a little bit more thoughtful and careful about not only surgeon but also center selection, and then thinking about if we have a higher or lower likelihood of having issues afterwards with that different anatomy. I think it's a fair response to it.
Yeah, I think if the question is, can these plastic tubes or Dacron tubes be used to replace other large blood vessels, whether it's to make a new pulmonary artery or a segment of aorta or branch? The answer is yes. These materials have been used since the early 1950s to replace parts of the aorta, and they hold up. They hold up very well. The frequency of complications related to it, or they don't wear out. And if they're big and the blood is going through them fast, they don't even clot off. You don't need blood thinners for them. But so the short answer is we've used Dacron tubes in a lot of different situations for more than half a century, and it's not perfect, but it is a really good substitute for any large blood vessel. They don't work as well in small blood vessels.
And you often won't see them used quite as frequently in children or in growing people because they don't grow.
They don't grow.
So there are other materials that we can use that are more biologic, and even in some rare instances things that can grow a bit. But once you're Avery size, then we feel it's very safe to use this type of material. So there were some hands up in the audience.
I had a less complex question. Coming from a mom, we live in California. So would it be smart for us to get contact with you and set up information about my daughter, and also get you in contact with our pediatric neurologist and cardiologist, and we see doctors in San Francisco.
How old is your daughter?
She's 16.
So here's I'll give you the kind of short answer. Absolutely happy to be in contact with anybody. The way the legal system works here is that I can't write any sort of notes or provide any real legally binding advice in any state that I don't have a medical license in. So people even basically have to come here. Now, I will say, and I might get fired for saying this, is that we do this, and we do this in a little bit of outside of the billable world way. I think Patty Mussolino and Mark Lindsay are kind of the real secret key to me, and not because there's anything special about me, but because they're the ones that are going to really kind of do the full evaluation of all the genetic components and everything and decide, do you need anything from me? Now that said, and I'll put this out there to the community, and I'm sure Dr. Cameron feels the same. If anybody has a child that's going to be undergoing surgery, our strongest recommendation is just that you feel really good about that center's experience, the thoughtful approach. There are a lot of surgeons that can do this operation. A lot of surgeons that do hard aortic operations, but it's that I think that the volume outcome experience is important. Usually we're looking at places that have a high volume. None of you are going to find a high volume center because this is too low volume of a disease. But does that sort of answer your question? I think
nervous that something emergent is going to happen, and I'd like to have a plan in place.
Yeah. So if an emergent thing happens, right, which is a dissection or a rupture, as Dr. Cameron described, then the name of the game is getting to the sort of best hospital you can get to the quickest that has a good heart surgical program, because at that point the mission changes a little bit. The mission does not become fix everything and make a beautiful CT scan. The mission really becomes survival. And I'm not trying to be dramatic, but if a dissection happens, you don't want to be saying, well, I heard about this guy in Boston or at Hopkins. No, you just need to get to a hospital that can fix this stuff.
Yeah, well, I agree with all that, but I would also say, you know, you're not alone with this dilemma. There are lots of other connective tissue diseases like Marfan syndrome and Loeys-Dietz syndrome, where it's the same issue that you, even in an emergency, well, you need a center that has experience with this or similar diseases, and it's good to have a plan. Even if you know that your local center can't deal with it, it's always good to know what your other options are and what you might, and it's sometimes good to have a relationship with them ahead of time. But if you talk to, in particular, the Loeys-Dietz community, it's a smaller community compared to Marfan syndrome, but they have the same thing, and they have typed out sheets about how you manage an acute aortic problem and the importance of having identified a team ahead of time that is within a reasonable time.
Okay.
I have one slide, by the way, that I use a lot, wasn't appropriate here, but Mike Tyson, the fighter, there's a picture of him smiling with all his gold teeth. And then the quote from him is, "Everybody has a plan until you get punched in the face."
Right.
But you still need a plan.
Okay, thank you.
Yes, ma'am.
The question that I had was actually two of them. When you're going in doing an aortic root repair, you said with the smaller kids, you don't use sacrum.
Well, that sort of depends on the size of person. I mean, if you know, and the size of the aorta. I mean, you don't want to give somebody a conduit or a pipe that is too small for what their heart output is going to be later in life. So that's kind of the general answer there. It really varies.
I was wondering if it led to these kids having to have a second surgery to replace with a larger tubing.
Yeah, I mean, Duke, you're the best person to answer that. It certainly can.
It does happen. So we try to oversize and put a little bigger one in at the first operation to avoid that problem. But there are a few people who just need another operation as they grow. Obviously, it'll depend on how big or small they were at the first operation. By the way, Dacron is a great material. It's not perfect. I'll say it again. It's a rigid tube, and whereas an aorta has some compliance and flexibility to it, and that actually has some impact on what happens beyond the Dacron tube. We don't understand it very well, but I wouldn't want to have you leave saying this is a perfect substitute for the aorta, a normal aorta. Not quite, but it works really well for almost everybody.
Thank you.
I actually have 3 questions. One to play off of what she just asked. So at what age would the Dacron, like for Avery's case, she said she'd probably want another surgery, like the Dacron would fit her for the next foreseeable future. At what age does like the heart stop growing that you could put in Dacron for these patients?
Well, I guess your question implies, should you wait a little while so that you can get a bigger Dacron tube in?
Like it makes just after one aortic replacement versus like have it replaced now and then again because the child got bigger and needs a bigger one.
I don't want to go into too much detail, but the only time we actually kind of wait till things get a little bigger is performing a root replacement in a very young person because of it has an impact on how likely you can save the valve, and the valve is worth saving most of the time. But that's a little complicated. But in general, we don't. We do the operation when we think that the risk of having a big life-threatening problem from the aorta is greater than the risk of the surgery. That's the time to move ahead and not try to think a lot about how much more growth we'd like to see before replacing the aorta.
I guess that also brings up my second question is like the aortic valve. So with the aortic valve, isn't there like a lifespan for how long the valve can last depending on what you choose? Like I've heard of the pig valve. How long did those last?
That's a good question. And that gets to why Dr. Cameron just said that if we can preserve native valve tissue and you can do that effectively, it's the right thing to do. In my experience, I've done 2 replacements for this disease and I preserved one and didn't the other. the complexity of these operations, particularly with this disease, are pretty challenging. And adding the valve sparing component to it is a more unpredictable operation. So it he won't like that I say this. Duke Cameron has probably done, I think, has done the most valve sparing operations in the Marfan community of any surgeon in the world. And so he has an incredible experience with this. But at the end of the day, you cannot have a good long-term outcome if you do not have a good short-term outcome. So it is an intraoperative decision to say, what has happened today, and how likely am I to be able to do this and leave a durable result. And if you leave behind a valve that is not a native valve, you are going to have to deal with that later in life. That may be 8, 10, 12, 15 years down the road, but you have a good outcome. And so I think the surgeon, and this really is the surgeon, has to make a decision intraoperatively. Anybody with a working aortic valve that needs a root replacement that is young should be operated by a surgeon that has in his or her practice the capability of sparing it. I believe that very strongly. But there are a lot of intraoperative game day decision making that may result in you needing to deviate from that plan. Does that make sense?
Yeah, and here's my last question, I'm sorry, hopefully it's a quick one. Did any of these patients, were any on beta blockers? And how effective was it on slowing down the progression of dilation?
Well, I think Mark, Lindsay, and Patty would be great people to talk about this. We put, there are 2 drugs that come up a lot in terms of stabilizing aortic dilation. What a beta blocker does is it reduces the wall stress on the blood vessel. And then another drug, which is called losartan, or that's an angiotensin receptor blocker, has also some scientific data to say that it might help stabilize growth. My own personal theory is that all these drugs lower blood pressure, and the lower the blood pressure is, probably the less you're going to dilate. And if you can tolerate a lower blood pressure and you already have an aneurysm, that is probably the main benefit of any of these drugs. There may be other magical features, but really that's it. Lower blood pressure results in less stress on the pipe and therefore less growth. Do you give me that?
Right, I agree. Beta blockers have been part of the regimen, medical treatment for aneurysms since the 1970s. But people are still arguing about how effective they are. But because they're so well tolerated, and we think that there's some benefit, they continue to be used. So, but I just wouldn't accept it as a universal truth that they are highly effective.
Yeah, and one thing to add is that, and I don't know, Duke, you and I have never talked about this, but I find that young people tolerate them a little less well than older people. A beta blocker. Beta is your fight or flight. It's your energy. It's the sympathetic nervous system. So when you block beta, people sometimes feel a little dull. They feel a little bit fatigued. And I just tend to notice it a lot more in the younger patients. So I think high dose beta blockers might result in people feeling lousy, getting a little bit dizzy, being a little bit anhedonic, or lack of energy. But a low dose adjunctive beta blocker that is well tolerated, I think, is probably a good idea.
In your presentation, you primarily had female patients. Have you noticed that males present identically, or are there different implications in the progression?
I've never met a male with the disease. There are males. I was just saying, I know there are males. I have a male that's going to come visit me. But I would say ask Patty and Mark about the real. This is more common in females.
Yeah.
I don't know why. I bet you do. But I don't know. Do you know?
I can answer that.
Oh, yeah.
So it tends to be that boys are more severely systemically affected and girls are more neurologically affected. So boys don't have as high of a survival rate, unfortunately.
And that's probably being born. Boys aren't born with this disease as common. Is that?
They're born equally like to females, but they just don't survive as long.
Well, then in my case, child's mild for some unknown reason, but.
Yeah, I was just gonna say, but everybody's child here, if you just look around the conference and you see all these kids, they're so different. Like, and that's the problem with a rare disease. We don't have enough.
Data.
Some things are very common, but even though those things that are common, it manifests differently in everybody, like, like the GI piece is very common for everybody, the aortic piece is very common. But even in those three cases, like Dr. Bloom pointed out, all of those aortic dissections, or they weren't dissections, but were very different, like they're all different.
I guess if you were looking at it from a more broad basis of aortic dilation, would you expect the males to present the same as females, or are there different implications between a male?
I mean, only in that males tend to be larger than females, that there could, but I don't, we don't bias by gender when we make decisions about intervention thresholds and things like that. Sometimes we bias by body size, which could lean you towards waiting to be, if the male was 6'3", then that might be different, but not because of the chromosomes or the gender, but just because of the translation to body size. And your point is exactly. One of my patients was diagnosed, 6 months before I met her, and has lived a completely normal life. They had no idea that anything was wrong with her until she got her chest in. So the expression, the phenotype, there's a lot of variability in the presentation. This has been incredible. I'm actually on my way to the airport now for another aortic meeting. I can't stay any longer. And I think Duke, you're also. But thank you all. It's been really wonderful meeting so far. I wish I could have stayed for it more, but we appreciate the invitation.
Thank you.